Thank you. Thank you, Dr. Rosamund, and thank you very much for your invitation to come and present today. I've been looking very much forward to my visit to the Mayo Clinic. Well, at the risk of dating myself just a little bit, I will tell you that I remember the party line that my grandmother had when I was growing up, and I would go to visit her in rural Nebraska. And for those of you who may not know what the party line is, essentially it is a shared telephone line, or it was a shared telephone line, and it was strung across the prairie, and all of the homes or the farms in a particular geographic area used that line. So when Esther called Ethel, all of the phones on the line would ring. But by virtue of the number of rings or the sequence of rings, Esther would know that that phone call was for her. And now Esther and only Esther would pick up the phone and talk. And we all knew that the phone was now off limits until that conversation was finished. Well, perhaps I had a little bit too much Nancy Drew coursing through my veins at that particular time, but that was a very intriguing concept to me. There was a conversation that was happening right there. It was happening right now. There were people talking about a subject that I'm sure was very, very important, but I was not part of that conversation. I had not been invited to be part of that conversation. Well, I think it's certainly fair to say we have moved way beyond party line technology. But I also think it's fair to say that we have not moved beyond party line communication in our communities. We tend to gravitate toward those individuals who think most like us. We tend to covet our ideas, and we tend to only dial up those folks who we believe have the same loyalties, or certainly who will not disagree with us, because that's our comfort zone. That's what makes our work easiest. But given the topic of this particular theme of the conference, good decisions, I will also assert to you that I don't think good decisions, and especially good community decisions, can be made that way. I think there has to be expansive discourse. I think there has to be room for disagreement. I frankly think sometimes we have to sit down at the table with people who have different loyalties, and even perhaps people we don't like very much. We have to be willing to sit down and make decisions for the community in a diverse and expansive way. I want to share today with you a conversation of a different sort that happened in our community. It was a conversation between two competitive hospital systems. It's a way that they began to look at each other differently, how they broke the party line protocol, how we were able to open up the lines of communication, and how our community had a different kind of conversation. They connected in a different kind of way, and they led to some very significant change in the healthcare landscape of our community. This is all set in Nebraska. Specifically, I am from Lincoln, Nebraska. We're a community of about 250,000. We're a growing community. We're home to the University of Nebraska, and also we are the seat of state government. What a lot of people may not know about Lincoln, Nebraska is we are an increasingly diverse community. We have about 50 or more languages spoken in our Lincoln public schools. The reason for that is while we may not be a gateway city for this country, we may not be the place that folks enter this country, we are the place where people settle. We are one of the highest refugee resettlement communities in the country. This is the place that many folks call home when they arrive here. And what makes that unique and special about our community is the face of the typical Midwestern community is changing, and we're beginning to have to shape our conversations differently because the voices in the community are growing more diverse. The organization that I represent is the Community Health Endowment. We are a municipal endowment that was created from the sale of a public hospital. We have assets of about $55 million. Not a large amount in some respects, but certainly to our community, it's significant. We fund innovative and collaborative healthcare initiatives, and our ultimate goal is simply to make Lincoln, Nebraska the healthiest community in the nation. What I want to point out is our philosophy, and we believe strongly that there is a big, big difference between making a grant and making an impact. We want to make an impact. We believe that our place in the community, which provides us this 30,000-foot view where we can scan the horizon and we can look for potential partners, we can look for people who should be working together, we can bring those people together, we can roll up our sleeves alongside those folks and help those conversations start. We truly believe that our role is as a convener and an encourager and a matchmaker and a mediator, and perhaps, but not always, as a funder. And I think there's someone like this in every community or more. I want to talk to you about conversations because I really believe that they are what has been at the root of every successful initiative we have started. And I'm not talking about formal kinds of conversations. Some of our greatest successes have resulted because we initiated a conversation, or perhaps we had joined it, or perhaps we even overheard it. These are conversations that are often the kind that happen over a cup of coffee, and you leave the coffee shop with notes on the back of a napkin, or these are the conversations that happen in the hallway in the break of these meetings. That's where conversations happen. That's where people begin to connect. But conversations, we believe very strongly, will lead to the fact that they can or cannot be shaped in isolation. And we see no value in shaping ideas in isolation. And we certainly see no value in others shaping their ideas in isolation either. Well, the story of this one particular initiative I want to tell you about today started when the Robert Wood Johnson Foundation and the George Washington University came to Lincoln a few years ago, and they studied our safety net, our healthcare system for our lowest income and most vulnerable patients. And this was one piece of data that they discovered, that about a third or more of the visits to our Lincoln emergency departments, those patients could be safely treated outside of the emergency department. That's not a shocking statistic to any community across the country, but our hospitals did want to address this, and they came to us. And they wanted to address it separately. They each had their own ideas for how it would work, how they could help their hospital address this issue. We contended that the overuse or the inappropriate use of emergency departments was not an emergency department issue. It was a community issue, and it needed a community solution. So while these two competing hospital systems wanted the same outcome, their historical and traditional instinct and natural instinct was to approach it independently. We said, come to the table, the same table preferably, at the same time preferably, and have a conversation about how we can work together on this community issue. And their response was, that would involve sharing records, and that would involve sharing staff, and that would involve sharing our locations, and that would involve sharing our ideas. Just trust us, it's better this way. Let us develop this in isolation. Essentially, they were telling us, let us dial up who we want to dial up. Our job at that point became to be intentional, strategic engagement of competitors, to bring them to the table, to ask simply for their time, to keep them motivated to the idea that this was not a solution that was going to be found inside the walls of one emergency department. It was going to be found through community conversations. So what happened? The two questions that always arise when you bring people to the table, and especially competitors, those two questions arose immediately. And what are those two questions? I hear it every time we bring people to the table. How much is this going to cost me? Very first question. And my response is always the same. I have no idea how much it's going to cost you. I have no idea what it is. We're having a conversation. I don't know how much it's going to cost me, but I'm here. Let's have a conversation. Let's discuss the issue. Let's set that aside. We'll come back to it. And the second question that arose, and is probably even more prevalent in these kind of conversations, is, so who's in charge? I don't know who's in charge. I don't even know what needs to be led. So one of our jobs was to get them to move beyond those questions, which they did. And what I've always found is that those questions naturally answer themselves as the process continues to everyone's mutual satisfaction. And in this case, it did. So out of this conversation, a program called ED Connections was born. It was a joint case management program offered out of all of our EDs. We have 2 competing hospital systems, but 3 emergency departments. ED Connections was born. And what did these hospitals have to do to achieve this program? They had to share their staff. They had to share their records. They had to share their information. They had to share their vision. They had to do all the things that they said were impossible at the beginning. But what did they get as a result of doing those things? They got the shared benefit of this project. Specifically, I can tell you right now that for the folks who are enrolled in this ED Connections program, non-emergent visits have decreased by 79%. In that same group, the overall cost to the hospitals have decreased 66%. It's having significant impact on the hospitals. But what I can also tell you is that what they are seeing and what they most appreciate about all the effort, and this is a process that took a year or more of intense deliberation and compromise, was that they are seeing it change the lives of the people they're serving. The team of ED Connections team tells me specifically that the kinds of results they're seeing is that these folks, 100% of them now have a primary care physician. Almost all of them have actually visited and are seeing that physician on a regular basis. Most all of them have increased their health functioning. 79% have increased their knowledge of healthcare choices. These folks are changing the way that they enter and operate in the healthcare system because these 2 hospitals chose to come to the table and have a difficult conversation. I want to give you one example. I want to tell you about Tom. Tom gave me permission to tell you about him. Tom was one of the first enrollees in ED Connections. He's schizophrenic. He came to our community. He had no medication. He had no support system. He was homeless. And he was using the emergency department, first one, then another, and then another on a repetitive basis, 2, 3, 4, 5 times a week. This is what Tom had to say about his experience with ED Connections.
Through ED Connections, I got a wonderful apartment. In less than 24 hours, they got me hooked up with the VA. They got me checked in with the psychiatrist. Out at the Veterans Hospital right now, I'm going to group meetings once a week, and they really help. I haven't heard voices for 4 years. This makes about 4 years this time of the year. Right now, I'm doing real good with my doctors. I go out there once a week for group. I'm taking my medication. ED Connections helped me get my life back together. They told me to go get keep my doctor appointments. They got me hooked up with Social Security. They're just a fantastic organization. There's no telling the ends that they'll do for you.
2 hospitals came together and had a tough conversation. They agreed to come to the table as competitor, and Tom got his life back. I can also tell you that what it means to an individual is important, but it's also what it's meant to the community. For years, we were trying to implement EKGs from the field, being able to send EKG information from the site of the patient to the emergency department. The 2 hospitals couldn't agree on how to do this. The same people that were able to create ED Connections brought the other people from the hospitals to the table and said, let's talk about this issue now. And just 2 months ago, Lincoln now has a fully integrated EKGs from the field. The 2 hospitals and our Lincoln Fire and Rescue are now operationalized this technology. And again, it was because the hospitals agreed to decide that the solution lied outside of their walls. I just want to close today by asking if you can think about who plays that role in your community or your organization. Really, who is it that has the ability to connect people and to connect competitors? I think every community has someone like this. Who is it that people trust in your community? And what was the last conversation that you had that resulted in something big, something that transformed your community? What good decision did you make that could lead to the way that the healthcare is viewed in your community? And if that hasn't happened yet, why? All I can tell you as I close today is these conversations between two competitive hospital systems changed our community in ways that we never imagined. And I would encourage us all to think about how we can do that in our communities today. I thank you very much for your time and for the honor to be here.